Hello and welcome everyone to the ESRD National Coordinating Center Learning and Action Network, or LAN, for reducing hospital admissions and emergency department utilization. We are going to begin now. We have 3 presentations today. My name is Sarah Eve Schaefer. I'll be facilitating this. Starting September 12th, we reduced the time for these calls from 1 hour to 30 minutes. We're still kind of finding our sweet spots. We might go to 30 to 40 minutes, but please stay tuned as your schedule allows. Just a few slides from the NCC before we move on to 3 network presentations. Mean Logistics, everybody is on mute. This call sometimes get rather large. We'd like to use chat instead. The call is being recorded, and we will post the recording of this event and the slides. We will send those to the we will send those to the ESRD networks, who will distribute in their service areas. As we start our presentations today, we like to think about ways to spread what you've heard today in your daily work. And so please listen and share approaches, questions, experience in chat. We'll test that out in a minute. Think about how you could use the information shared today at your facility. Also, we ask you to think about applying one idea from today's LAN at your facility and share these learnings with your colleagues who did not attend today. So we're going to test out chat and ensure that is working. So if you go over to chat, please do select to everyone, and you can enter in, have you previously used best practices from the ESRD NCC change packages to improve outcomes or processes at your facility? If you haven't used the change packages, there is a QR code there. If you put your phone camera on that, you'll be able to go directly to all of our change packages. Thank you. Okay, it looks like chat is working. We have some yeses in there, so we know chat's working. So again, as we go through the presentations today, if you have questions for presenters or panelists, please just pop those in chat, and that's the easiest way to get your questions answered. With that, we are going to start with Network 4 today, and that is Andrea Sonson. Andrea, you ready?
I am ready. Thank you, Sarah.
Excellent.
Okay, so good afternoon, everyone. I am Andrea Sonson. I am the Senior Manager of Clinical Quality with Fresenius Kidney Care, and I currently cover the Eastern and Western PA regions, which also is inclusive of a few facilities in Jersey, West Virginia, Maryland, and a little bit of Ohio. I am speaking today on behalf of the FKC Parkview facility team to share their story with marked progress in hospitalizations. I have worked with this facility team over the last 10 years, and with this specific QA project with Network 4, I continue to work with this team in supporting their efforts and participating in their team discussions. Next slide. I want to start to share some information about Parkview, and this introduces to you the Parkview interdisciplinary team. Parkview is located in the northeast section of Philadelphia, and the team members have been a constant in the facility with many years of experience and longevity, both with the facility and within the dialysis community. I want to stress that this is a very highly engaged team, and they truly demonstrate the epitome of implementing an interdisciplinary team approach, as well as work to support a facility culture of communication, collaboration, and coordination. Next slide. So Parkview is the largest facility in the northern Philadelphia area, and they currently have and maintain about 130 in-center patients. And they have a home program as well with about 12 patients. There is a diverse patient age group within the facility. They actually have a very small nursing home and skilled nursing facility population. Parkview also is located within a low socioeconomic community and has a high Spanish-speaking patient population. The team has identified that many of our patients have low reading and health literacy. And I also wanted to include in the bottom 3 boxes here some additional key points based on my observation and working with the Parkview team. The patients are very receptive to information and education that is provided to them by various team members. And the patients have a very high level of trust with this team. There are 3 nephrologists, one being the medical director, additionally 2 nurse practitioners that cover Parkview, and they are all from the same practice group, and they are all very equally engaged and very supportive. Next slide. The Parkview QA project was initiated in the spring of this year, and looking at option year 1, which ran from May of 22 through April of this year. The goal was set at 3.86, and at that time, Parkview came in at 4.156, so well above. The hospitalizations or the priority diagnosis codes for this are outlined in the middle here, having various diagnosis codes under blood pressure management, fluid, infection, anemia, endocrine, and vascular related diagnoses. So this was clearly an identified opportunity for us to review in detail our current practices and identify what we can do to improve patient outcomes. Next slide. So our first step actually was conducting a root cause analysis for Parkview, which is shared here with all of you. And we started by evaluating the last 6 months of the hospitalizations, as well as readmissions, to identify where our biggest opportunity was. The root cause analysis was completed using a specific RCA tool. And I really want to emphasize that this was also completed with full participation at one time from the clinic manager, the charge nurse, the dietitian, and the social worker. Once this was completed, we were able to identify our top 2 root causes, which is located here at the bottom, which were GI, endocrine, and cardiac related hospitalization. There was a team discussion around our current practices and processes that were already in place and how we managed our delivery of care, as well as what our follow-up looked like with our patients in that post-hospitalization phase. And again, one of the things that I think is very important is that this team discussion involved the current practices and the experiences from everyone's perspective. So not just one person, the manager, but really the input from the manager, the charge nurse, the dietitian, and social worker. So each member participated in what their role is and what may need to be done differently as a team, and where there was opportunity to make change that would lead to better outcomes. Next slide. All right, so this provides a summary of the details of their action plan and what processes they tweaked. So some of these things were processes that the facility currently was doing, but we identified that there were actions that we can take, as well as be a little more specific and measurable as far as having that process in the facility. So at the very top, around discharge summaries, the nurses retrieve and review the discharge summaries post-hospitalization, and training was completed to ensure that all nurses knew how to obtain via our health information exchange system. And then the RNs provided those summaries for review to the providers and the extenders with their weekly rounds. Post-hospitalization report, I will explain more about what this report is in detail in the upcoming slide. This particular report was being used, however, the process behind its review was not solid. So the change was that the facility the administrative assistant would run the weekly report and provide it to each of the team members. So this was inclusive of the nurse, the manager, dietitian, social worker, and provider. And they would review to ensure that all key points were completed and there were no outstanding follow-up points with the patient. Additionally, the team also identified upon the review if there were any patients who may need to be deemed unstable from the comprehensive interdisciplinary assessment and plan of care process based upon their individual review. The red flag patient education for each patient was implemented. Again, I will review some of the specifics around what this is, but using the red flag education was a new process that was integrated into their workflow that they continue to implement, but it really serves as a really good way to educate the patient about their hospitalization and to be able to do that in a way that was understandable for the patient. The physician and extender also is participatory with fluid management. This facility does follow a fluid management algorithm. We ensured that all of the nurses were trained in the particular algorithm and what interventions to implement. So that process has been solidified within that facility. And in addition, when those providers make rounds, they are provided a list of specific patient outliers for them to also review to see if any additional orders are necessary. One of the key things that this facility does that was not new, but that I think has a huge impact, is the physician, the medical director makes himself available specifically for a monthly meeting. And this monthly meeting is inclusive of all interdisciplinary team members. And they identify ahead of time what metrics to review based on facility outcomes. So 1 month it may be fluid management and CBCs greater than 90 days. The following month it might be anemia and albumin. But during this particular meeting, they review outliers for each of those metrics, and they ensure that there is a plan in place for these patients. They share experiences, they share ideas to see how we can improve not only outcomes, but also to ensure that the patients have the resources that they may need. In addition to that, they certainly have their monthly QAPI meeting. This facility team does an excellent job at sharing their specific action plans at their monthly QAPI meeting. They review how things are going, what might need to change, are the interventions that were identified happening, as well as communicating any additional steps that they want to add to that. The clinic manager, as well as the charge nurse, also will host huddles with the direct patient care team. This team is not just inclusive of the interdisciplinary team, but they do an excellent job in taking that information and taking their QAPI meeting findings out to the direct patient care team. They do share outcomes, they communicate needs, they communicate the processes that are being put into place with the rationale, and they also elicit feedback from them. What are they finding in caring for our patients? What are their experiences? It is a very close-knit, very well-supported facility team. Next slide. So this is sharing with you what our post-hospitalization report details. This report is generated from our EMR actions and documentation. So it really is a check and balance of what we want to happen when the patient returns to us. This report provides to us hospital admission, discharge, and the return date, so we can see how long and what those diagnoses are. It will also capture additional details, confirmation that we reviewed medical records, especially with the discharge summaries. It provides information as to whether there is a documented follow-up from the provider, the dietitian, as well as the social worker post-hospitalization. It also captures whether we did a medication reconciliation upon return from the hospital. So this is very important as well as ensuring that our patients get their labs reviewed. There is a follow-up section for anemia management, any access evaluation, as well as fluid status. So was there any change in the dry weight? And how is the patient presenting to us post-hospitalization? It also allows for us to identify any additional patient education that is needed, as well as care coordination with other providers. With that patient education, that is where that red flag education is going to come in, which I'll explain in the next slide as to what that looks like. Next slide, please. So we have patient education materials that are titled the Red Flag Patient Education, and it is a one-page document that we work with the patient one-on-one. So predominantly it is the RNs who review this information or the education with the patient, but the information is also shared with other team members. And the purpose of this is to identify and to ensure that the patient understands why they were hospitalized. So if you remember in the very beginning, some of our patients have low health literacy, so they don't always understand medical terminology or meaning or signs or symptoms or prevention. So this allows us to be able to put in terms that they will understand why they were admitted. It also identifies flags for signs and symptoms of hospital diagnosis. So, for example, if they were admitted for pulmonary edema or CHF, what are some of those signs and symptoms that the patient might experience that would lead them to believe that they might be at risk for a hospitalization? So it lists that for them. And so we review that with them so they know in the future, if they have any of these signs or symptoms, they know to report it to the facility team members. There is a section that's titled What I Can Do. And this is a list of preventative actions or interventions to avoid admission. So although there might be a list of several items, we have a conversation with the patient for them to identify one or two items that they think they can commit to. And this might be something related to fluid. It could be something related to catheter care. So there's a whole list of things that allows them to reinforce the understanding of what to look for. And then at the very end, there is a rating scale of 1, meaning not sure, all the way to 10, very sure. And the question it asks them is, this is how confident I am that I can do this. And this is really referencing the third bullet point. So they rate it themselves on a scale of 1 to 10, or that they're confident that they can commit to the actions in that third, what I can do. And I think that this has really allowed the patients the opportunity to understand what is contributing to their individual hospitalizations. This is something that the team is very committed to doing. The dietitian and the social worker were very participatory in organizing all of the different red flag and organizing the information to make it easier for the RNs. So this really was a team approach into ensuring that our patients were a part of this as well. Next slide. So what were the results and what did we identify as some of our adopted best practices? So in looking at option year 2, so that started in May of this year, and we're still, I have the date wrong here. This is the going from May to October results. So the year goal is 3.98. And although we're only halfway through the option year 2, we are at 0.96 with only 2 admissions for those previously identified diagnosis codes. So this facility has done an amazing job in really reflecting on what they think really made a difference. the high level of interdisciplinary team communication and sharing is unbelievable at Parkview. There is not a team member that cannot tell you what is happening in the facility, what each role is doing to support the patients, and they have very engaging conversations. They involve all team members. So again, this is not something that is only the clinic manager and the charge nurse or just a physician. They involve all direct patient care team members. The level of support and engagement and commitment on the physician and the extenders is extremely impressive. So they're not there to just make rounds. They take additional time to sit as a team to review outcomes. They review facility processes, the level of detail that they engage in CIA and POC or plan of care meetings. If they need to schedule 6 additional meetings that month to review that, that's what they do. The utilization of the weekly review of the post-hospitalization report to ensure that we have definitely captured each of those key items, as well as the red flag patient education material, they felt had the biggest impact. I do want to mention as well, with this patient population, they do use the hospital system as their primary care. We were provided patient education materials from Network 4 and helping us outline the top 10 reasons to have a PCP. We have also utilized those patient education materials with our patients, and it has definitely helped providing that talking point with our patients to ensure that we can help them seek that primary care. Next slide. I believe that is all. And that's all I have for the presentation. I want to thank Network 4 and Jeanette Schritt for all of your support as well, and providing us additional tools and patient education materials that has been very impactful for Team Parkview. Thank you, Sarah.
Excellent, Andrea. Thank you. One quick question that somebody put in chat, which was, does the facility bring in CCHTs or PCTs into the discussion?
They do. So when we talk about direct patient care in the previous slide, so they communicate with the PCTs during their huddles to ensure that they are aware of any quality improvement projects, as well as elicit information from them. What are their experiences? What are they seeing? Making sure that the goals that they have are shared amongst all team members, not just interdisciplinary team.
Excellent, thank you. And to answer Ada's question, yes, the slides are sent from the NCC to the ESRD networks for distribution in their service areas, and then there will also be a recording of this posted on YouTube. Thank you so much again, Andrea and Network 4. We are going to move on to Network 5 with Caitlin Booth and Rebecca Dudley. Caitlin, you ready?
Yes, thank you. All right, we can move to the first slide here. And actually, next slide. Thank you. I am Caitlin Booth. I'm a quality improvement specialist with Network 5. We are actually a sister network with Networks 3 and 4. And we cover West Virginia, Virginia, Maryland, and the District of Columbia. And I have with me, she's going to talk the rest of the time, but I'm going to give you a brief rundown on the facility where she is the administrator at. This is UVA Appomattox, and it is a pretty rural facility located in Appomattox, Virginia. They have 17 stations, and it's actually a facility that we visited for an on-site visit a few months ago. And while we were there, we learned that about 50% of their patients struggle with health literacy, and a majority of their patients also struggle with behavior change, which, as we know, affects hospitalizations. Next slide, please. So a brief overview of their current data. This is their data through October 31st for this measurement period. And right now they have 4 admissions, which gives them a rate of 3.54. Their baseline last year was 8 admissions, which gave them a rate of 3.448. Now, because this is a smaller clinic and they don't accumulate quite as many patient months, their admissions really affect their rate, the way that that is calculated. But currently, they are still below their baseline. Their goal for this measurement period is to stay below 8 admissions so they can meet their goal. And currently, right now, they are meeting that goal. That's just admissions. Their ER visits are at 0 and their 30-day readmissions are at 0, which is an improvement from their baseline period. A summary of the diagnoses that they have right now for this measurement period are they have 1 bloodstream infection, and they have a hyperkalemia, and they have 2 fluid overloads. And again, I put a little asterisk down there. This is all based off the CMS ICD-10 codes that we're looking at. The facility's data is always slightly different because they do track all of their hospitalizations. Next slide, please. And I'm going to hand this over to Rebecca at UVA Appomattox now.
Hello, everyone. She said we're pretty rural and we've been open for 7 years and we've had really high hospitalization rates since we opened. And we knew the barriers going into looking at our numbers included our health literacy as well as patients not having PCPs for preventative health services. So those were areas we knew we had to work on. It's also fair to say that we've had 5 medical directors in the 7 years that we've been open. So that's been a struggle that we've had as a facility, and trying to get someone stable so that we can build our relationships in the community with other healthcare providers to help with some of the preventative measures to keep these patients out of the hospital. So we started this with QAPI, and it was second medical director in that we decided, okay, this is truly a problem that we really need to focus on as a group, and worked with the dietitian and the social worker as well to try to find ways to connect with the patients and provide education. And we sat down and really worked as a team to come up with our root cause analysis, to look at everything to see why they were going to the hospital, why they were reaching out, and they felt like they needed to be at the hospital more for problems that we probably could have prevented much quicker than allowing all that to happen. So what we did, we decided to include our mid-levels in on the discussion as well so that they could help provide some insight, because as you know, the mid-levels that see the doctors sometimes spend probably a little bit more time getting to know the patients and understand more of the health literacy issues with them. So they were able to speak to, hey, this is what's going on, and they were able to kind of cater some of the care and some of the interventions that we were working on to help individualize and get these patients on track to where they needed to be. Our social worker worked with a lot of the patients to find primary care physicians so that they could get things lined up to do their preventative health that they needed to do. So that's what we really did. Our direct patient care staff that we utilize in the facility, they were also brought in as far as our morning huddles. We have huddles every day, and we discuss the ongoing issues with our patients. And it's an opportunity for everybody to speak so that they know what's going on and what our focus is for the patients. So if there's problem areas, that's where we tailor our education to staff to say, hey, when you're talking to patients this week, let's talk about, medications and compliance with medications, even down to diet for hyperkalemia issues as far as the high potassium foods. Patients always like to talk about food and what they're going to eat when they leave or what they've had to eat. So that was a way that we incorporated our direct patient care staff to say, hey, don't forget to take your binders. So we've done a lot of different things as far as education with staff to help with decrease in our hospitalizations. Next slide. When we looked at all the problems when we were doing our root cause analysis, the first one was a lot of cardiac, chest pain, hypertension issues that we were seeing. We've had patients that's had cabbages. We went for probably a year or two and didn't have any GI bleeds, and then we had 5 or 6 in a year, which was kind of different. So we were looking to see if there was something going on different with that, with our mid-levels and our physicians to say, hey, let's look at this and make sure, if we know patients, the ones that are having these GI bleeds, we made sure they had their PPIs, and just truly we went through so we could tailor, because every patient's different and their needs are different. So that's what we've worked on as a team, to try to individualize and pick out the areas that we knew that we could help them the most and try to keep them out of the hospital. Compliance is always a big issue for patients, and those are the ones that we have with the fluid overload admissions that's missed a couple treatments, or they've shortened every treatment for the last week and then they miss a treatment and they get in trouble. The hyperkalemia patients, we've got a couple that will miss, and they even have their potassium binders that they take, and they, of course, with their medication compliance, they don't take those either. So those are all areas that we've worked with patients individually to try to improve that. The numbers have gotten better, as Caitlin talked about in the prior slides. So it's truly been a teamwork approach to come together to try to figure out how we can decrease this. And working with our network back in May and in the June timeframe, I talked with Caitlin, and they had a hospitalization tracker that she kind of offered for me to utilize and put my information in and see if I liked it. And if you'll go to the next slide, I'll talk about the tracker that we've been using. This is a slide where, it tracks everything about your patients and the admission and the reasons. There's a category for diagnosis that you can populate, and it puts it into a really nice graph for you to look at that she showed you on that second slide. It kind of works where it breaks it down. And like she said, this was only the ones for the ICD-10 codes that really qualify for my hospitalizations. But I went back to January and I counted every patient that had had a hospitalization on the tracker. And it's so valuable to see the information and how it populates and divides out what's actually going on in your clinic and what the major problem areas are to focus on. We've had a lot of cardiac related issues, and we say cardiac, we know this is all from their diabetes and hypertension that they've had for years that are causing these issues. But it gives us a start as far as when new patients come in, what to talk about as far as their medication compliance for their diabetes and or their hypertension. Let's go to the next slide, because after you utilize this tracker and put all the information in, it populates to tell you, she spoke to, we didn't have any ER visits or any 30-day readmissions. It pulls that information over and it shows you your admission rate versus your ER visit rate and your readmission rate, which is really nice. In QAPI, we're talking about a lot of numbers, and I found this to be helpful because it's a quick viewpoint, and you can say, okay, looking at our admission rate, this is what it looks like, and this is what it's related to. And it kind of captures their attention and their focus, and it helps to zone in when you're working with your team to say, okay, wait, maybe this week we should work on this for education, or this month, or let's plan on this for the next month, and put that in your corrective action plan. So the diagnosis category summary, it breaks it down for cardiac, electrolyte imbalances, your pulmonary, your neurological, gastric related, and your fluid overload. I found this really helpful, and the team has liked it. Like I said, it's a quick viewpoint, and you're able to move forward and get what you need done out of this. So we've really enjoyed using the tracker. I know we all have different root cause analysis spreadsheets and trackers, but I've enjoyed using this with Caitlin, and she's been a very big help for this. Any questions? Thank you.
Thank you, Rebecca. As a reminder, if you have questions for Rebecca or Caitlin as they work through this process, very thorough. Thank you so much. Love seeing the data and the process and the time and care you took. If you have any questions, you can please pop those in chat. If not, we will move on to Network 6 and Katie Churba. Katie, you ready?
Yeah, I'm ready. Can you hear me okay?
You sound great. Thank you.
Hi, I'm going to be presenting for a Network 6 facility. You can go to the next slide. So Network 6 encompasses Georgia, North Carolina, and South Carolina. There's about 769 dialysis facilities, about 12 transplant centers, and they serve over 50,000 dialysis patients. Next slide. So the facility I'm going to be representing today is DaVita Boiling Springs Dialysis Center. They are located in Boiling Springs, South Carolina. They are open 6 days a week. They have 15 stations with one isolation station, and the facility provides in-center hemodialysis and PD dialysis. Next slide. So we took a look at their option period 1 metrics, and they had 4 hospitalizations, they had 1 unplanned readmission, and 7 outpatient emergency room visits. So they could use some work. So they have put in a lot of work in changing their practices. And if you go to the next slide, we will start discussing those. So first and foremost, they were able to increase their days of their clinic operations to 6 days. As this might not be able to be done for all facilities, I do want to make a note that if your facility is a 3-day-a-week facility and you're unable to open it up 6 days a week, it's really great to find a sister facility that you work with within your corporation and that you can be able to send patients to if needed. So the benefits that they were able to have by opening up 6 days a week, they were able to offer extra treatments for fluid overload. They were able to schedule flexibility for call-offs, for patient appointments, and for patients going on vacations. And during those extra treatments and switching days, they were able to increase their one-on-one patient education. When looking through their metrics, most of their ED visits and hospitalizations were due to fluid overload. Next slide. So they also have made a very unique way for when patients are calling off. They automatically give a patient another day to come in. So they have a little scripted saying that we're sorry you cannot make it today. We have you scheduled for 7:30 a.m. tomorrow. We'll see you then. Oftentimes it works. Sometimes it does not work for some of those patients that just do not want to come in. But their missed treatments are now trending more in a positive with this being said. But they do still continue to have some patients that just refuse not to. Next slide. And then they also have this really great mistreatment board. So when you walk into their lobby, each month they have a different board. For October, they had a corn maze, and for November, they are doing the turkey trot. And then in December, they're going to do ornaments on a tree. So each patient gets a corn husk for the month for October. And when the patient comes to treatment, they get to move the corn husk over on the board each week. And it's really seemed to help them kind of like a competitive way of making sure that all the patients kind of get over throughout the month on the board. And next slide, I have a really great picture that they provided for me that they're using. They have, I believe they have signed consents from the patients that they can use like a first name or a last name on the board. I'm sorry, I just saw the question in the chat. Oh, go ahead, next slide. So currently right now for this year, they have made it to 1 hospitalizations. They have had no unplanned readmissions and they have had only 1 outpatient ED visit compared to 7 last year. So I think they're doing a really great job, and they've really implemented some really great emerging best practices. Does anyone have any questions?
Excellent. Thank you, Katie,
Yes.
Caitlin, Andrea, Rebecca. Excellent job, everyone. So today we are going to wrap it up. If there aren't any questions in chat, we do try to keep these now to between 30 and 45 minutes, and we're right there. So please do follow the ESRD NCC on social media. And as I said at the beginning and in chat, the NCC will share the slides from these presentations with the presenters' permission, of course, with the ESRD networks to distribute in their network service areas. It gets kind of tricky for the NCC to actually email blast these out to all the facilities. So we do ask the networks to help us in distributing them. And when you close the event, there will be a short survey. So we do ask you to take that. The other question that we like to ensure you answer on that is about the length of these. Today we came in right around 40 minutes, which is pretty nice. So please, again, share best practices from this presentation, things you heard, inspiration with colleagues at your facilities. Continue to use the NCC change packages. The QR code is there again. We do update these every year. We're currently conducting interviews with top performers across all OKR change topics. So those will get updated and re-released every year, but they are currently on the NCC site. And again, just one last ask, if you can, please fill out the post-event survey. That helps us on the NCC side ensure that these match the needs of the attendees, which is you. Thanks so much for everyone today. It was a great discussion, great presentations. Have a great Thanksgiving and take care. We'll see you on the next call.